Hello students, I am Dr. Harpreet Singh. Today we will be talking about a very controversial and also an interesting topic, biceps and biceps-labral complex pathologies. So what is controversial about biceps? Almost all the things about the long head of biceps we are talking about. There's a lot of controversy about its main function. What does the long head of biceps do? What's its main role in the shoulder? The various pathologies, how do they present? How do we diagnose them? And how do we treat them? There's lots of controversy about this. So we'll try and remove those controversy and simplify the things about biceps. So where does the long head of biceps attach? So we talk about scapula, and if you look at the glenoid, so the long head of biceps attaches on the superior glenoid tubercle along with attachment on the superior labrum. So it is attaching to the bone, the superior glenoid tubercle, through the superior labrum. But it is this attachment through the superior labrum, this attachment has a very variable anatomy, so it's different in different individuals. So it can, this attachment of the superior labrum can have a meniscoid-like attachment to the glenoid tubercle. So what is variable? It can have a meniscoid-like attachment, or there may be something called a through the superior labrum there may be a presence of what is called as sub-labral recess. So what is sub-labral recess? So the attachment of the biceps and the superior labrum onto the bone, onto the supraglenoid tubercle is not very firm, and there is a gap, a smooth gap which is known as a sub-labral recess. Usually it's a small gap, maybe 1 to 2 mm. And how do you differentiate from a pathological lesion? Is that it's smooth, there is no fraying, there are no frayed edges of the labrum. There is a smooth transition from the labrum to the gap and to the glenoid. So this attachment of the long head through the superior labrum is variable in different individuals. So it's not that it's constant in everybody. So that's why when there is a tear of this part, that is there is a tear of the biceps attachment to the superior labrum, what we know as also call as slap tear. We don't know what was the original anatomy like. So if we go and repair that, although we are trying to restore anatomy, but since we don't know what was the original anatomy like, we may end up deranging the anatomy, so which may lead to deranged kinematics for that person. So this variable anatomy of this region leads us to not being able to deal with this pathology in a very coherent or in a very simplified way. What you need to remember is the anatomy of this region is different in different individuals. So if we talk about the function of this long head of biceps, we are talking about basically long head of biceps because this is the part of biceps which goes intra-articular. The short head of biceps is just attaching on the coracoid process, so it doesn't go into the joint, but it is a long head which goes into the joint. If you remember the anatomy, this is a left side scapula. I don't have a left side humerus, but if we take it to be, if you make this like right scapula and this as the right humerus, so when the biceps travels, it travels in the intertubercular sulcus between the lesser tuberosity and the greater tuberosity, and then goes up through the joint and attaches onto the supraglenoid tubercle. So it travels this intra-articular part. So what are the main functions of this long head of biceps? It is said that it acts as a humeral head depressor. Also it gives some power to the flexor function of the biceps, though the main flexor power comes from the short head, and although the main flexor of the elbow is your brachialis, but whatever function of flexion of elbow is coming from the biceps tendon, it's mainly from the short head. The long head has very limited function. It may give some power to the flexion role at the elbow. At the shoulder, it does depress the humeral head, so humeral head depression function, and some amount of stability in an unstable shoulder. So these are the functions, not very important, but yes, whatever the functions the literature tells us are these. So what are the pathologies which can occur in the long head of biceps? So you have to remember that most of the pathologies of the biceps tendon are usually secondary pathologies. There is very rarely a primary pathology of the biceps tendon. What do I mean by secondary pathology is that these pathologies are secondary to any other disease of the shoulder. So the biceps may become involved in as a part of impingement syndrome, or as a part of adhesive capsulitis, or as a part of a fracture of the shoulder, or some other disease process. So usually biceps pathologies are secondary to other shoulder pathologies. So what can be the biceps pathologies? Biceps pathologies can be, they may be tendinitis or inflammation of the shoulder, very common in other pathologies like impingement syndrome, in pathologies like adhesive capsulitis. So as part of the inflammation in these processes, the biceps tendon, I am talking about the long head of biceps, that also can become inflamed. So there is tendinitis of that long head of biceps. The biceps tendon can be ruptured. So it will, the long head of biceps ruptures from its attachment and classically presents as what we know as the Popeye sign. So clinically it will present as a Popeye sign. There may be biceps instability, or which may present as a subluxation or dislocation. So biceps is not in the groove, biceps tendon, instead of being in the groove, it slips out, usually anteriorly. Most of the times it slips out anteriorly because of some associated pathology. Usually it's a subscapularis tear. So what are the causes of biceps instability? There may be a pulley rupture, there may be a rotator cuff tear like the tear of subscapularis, or there may be some fracture of the shoulder involving the proximal humerus, which can lead to a biceps coming out of its groove. So what is the pulley? What stabilizes the biceps in its groove? So if we look again, this is not the same side, scapula and humerus, but if we take this to be the scapula and humerus of the same side, biceps coming here, attaching onto the superior glenoid tubercle. So the main stabilizer or the pulley of the biceps is formed by the ligament coming superiorly, or the superior glenohumeral ligament. So you have to remember that SGHL or superior glenohumeral ligament provides a lot of stability and forms the pulley of the biceps and stabilizes it in the groove into its position, so the biceps doesn't subluxate and remains here in its right position, original anatomical position. Also a muscle coming anteriorly forms a part of the pulley. So what is the muscle coming anteriorly like this? It is your subscapularis. So subscapularis along with the SGHL are the two main stabilizers of the biceps tendon and form a part of the pulley of the biceps tendon. So if we when we look at the intra-articular portion while doing arthroscopy, you can visualize the pulley